introduce themselves, and then if you've got slides to start sharing notes.
So I'll introduce myself. I'm Stephen. I'm the psychology co-lead for Tower Hamlets, and this will actually be my last trauma-informed community of practice meeting because I'm leaving my role in Elft at the end of the month. So Ryan and I are going to say a bit today about the work we've done together with Marisa, actually, in inpatient services in Tower Hamlets.
Thanks, Stephen. And I'm Ryan Wczasek. I'm a clinical psychologist and lead for inpatient services in psychology inpatient services in Tower Hamlets. Nice to meet you if I haven't met you before. I will share a few slides we've put together. So just give me 1 second. Oh, and just also a small heads up apology that my son's school is closed. So if I get a brief interruption, Stephen, I might just have to hand over to you for a second.
That's fine.
So Stephen and I we put some slides together really as a guide, but we'll kind of talk through some of the work that's been going on. Just to say, we do have some space for questions and discussion at the end, but if anyone does want anything kind of clarifying immediately, that's also fine. So I suppose we'll talk through the work we've been doing, but I guess just a kind of a brief bit of background before that, which is to say that in some form or another, the sort of trauma-informed care work in Tower Hamlets inpatient services has been going on for at least 4 years, probably a little bit longer now. And as a unit, we've got 6 wards, so it's all adult mental health inpatient services. We've got 4 acute wards and 2 psychiatric intensive care units. And I guess the idea has been floating around for a while, you know, of trauma-informed care in nursing circles, but obviously also in therapy circles. And I suppose what we want to talk a little bit about today is the way we've tried to move it forward with a bit more focus in a more kind of project management type way. And part of the reason for that is because of, I suppose, the idea that many people will be familiar with from when you've been trying to implement these things as well, which is that, you know, it's been around as a concept and as a way of perhaps changing the language and bringing about culture change for a while. But one of the things we were often kind of asked or tasked with from nursing teams in particular was, you know, well, what does it actually look like? How do we do this? Because I think everyone agreed that it was a good approach and a good way of thinking about things, but what does it look like pragmatically on the ground, and particularly for stretched services and services where people don't have a lot of time for kind of adding new things into their job roles, then you know, I think it's important we felt that we had something a bit more pragmatic and that people could actually follow. So I'll talk through a bit about how we've approached that so far and what it looks like. But I just wanted to give a little bit of the background to it as well. Stephen, please jump in if I'm missing anything or there's anything you'd like to add. And Marisa as well, actually. I didn't realise you'd be here, but please feel free to jump in. So we thought about taking more of a project management approach to this. And I suppose in terms of what we felt was needed initially, we've only really started this approach this year, was to have a kind of a guiding group, we're calling a steering group at the moment, which meets monthly and that involved eventually, we hope, kind of people from all levels who were involved in TIC, but certainly initially people who had the kind of power and influence to make some decisions and to think about what we meet some of the goals we were coming up with. We started out with myself, Stephen, the borough lead nurse, and some of the matrons and managers from the wards. And the idea really was to have a monthly steering group, but that we would have from that kind of individual projects that people were taking charge of, that we could then use the steering group as a kind of hub that people could update on and then receive any support they needed from the group and talk about any kind of challenges and barriers that were coming up. And we came up with a kind of initial structure, I suppose, that was based on 3 levels of trauma knowledge, so loosely sort of taken from the NHS Scotland framework that they used, but also other conversations that have been going on elsewhere as well. So basically the idea that starting out with a kind of trauma aware level of knowledge for everyone, for all staff, and I'll talk through this in a bit more detail shortly, but then also thinking into the future about how we can give people more skills to work with a traumatized population, and then also acknowledging that we also need kind of trauma specialist knowledge and interventions within the system as well. So within those areas, and again, I'll give an example in a moment, but we really felt that it was important to have kind of very clear goals that we could evaluate and meet within each of the areas we were coming up with as areas that needed to be worked on. And I suppose we also started with an acknowledgement and a discussion around the fact that a lot of work has been done in inpatient services over the years that is not necessarily labelled as trauma-informed care, but could certainly come under that, you know, and particularly work that's been done around safety in the unit, around reducing incidents of violence and aggression and reducing restricted practices, which would all kind of fit with a trauma-informed care philosophy, but hasn't been labelled as that. And I suppose a broader point I just throw in as well, which is that, you know, which comes up in our training sessions, that, you know, we work in our part of the service where we have to acknowledge that we cannot necessarily fully meet the all of the principles of trauma-informed care, in the sense that, you know, we are taking people's freedom away from them. We are not necessarily always giving people full choice in the care they receive because they are sectioned under the Mental Health Act. And we are also engaging in some level of restrictive practice with everyone, although we try to minimize that. So it was important for us to acknowledge that, but also to say, I suppose, that within the limitations of our system, we need to be as trauma informed and to adhere to trauma informed principles as much as we can. So that was really all our starting point for coming up with the areas we wanted to focus on. This is a kind of fluid working document, really, but this was just a kind of visual representation of the areas that we felt might be kind of important from a inpatient perspective to think about in trauma-informed care. And I won't kind of go into detail on every single point, but I suppose you could see the 3 levels there of thinking about trauma-aware kind of practice, trauma skill practice, and trauma specialist practice. And in the middle, we are some of the kind of initial ideas, either work that had already been done or was ongoing, or ideas that we felt were kind of priorities for improving. So those are all, the middle is almost more kind of change idea type thing. And on the left, we have what might be needed in terms of staff development and support in each of those areas. And on the right, we have what we needed to get in place in terms of service user involvement. So I suppose it's worth saying that, you know, I'll talk through some of these in more detail, but this is all at kind of varying stages. Some are started, some are kind of a little bit on the back burner, some are very active at the moment. So, you know, there is limited resource and we have to choose on what to focus in any given moment. And sometimes that depends on who's available or what the priorities feel like they are for the unit. But you could see, you know, roughly that there's a strong element of needing to train staff in there. There is a kind of thinking about the practices that happen on the ward. as well as thinking about some specific kind of interventions, particularly around kind of grounding, stabilization work, emotional regulation work. But then there's also an acknowledgement that we kind of need the user involvement as well to kind of push all of this forward. And I'll talk a little bit more about that as we go through. So this was, I didn't want to show the whole document because it's a bit unwieldy, but this is an example, I suppose, of one of the areas we've been looking at and how we've just been kind of starting to keep track of it. So again, this approach is fairly early stages for how we're going about things, but this is one of the things in the kind of initial stages, the kind of trauma aware stages, but also leads into a bit more of the kind of trauma skilled stuff as well. So this is particularly something we've been working on between the therapies collaborative that we have in the unit. So that's psychology, occupational therapy, and arts therapies. And it's thinking about kind of having what we've broadly termed a sensory strategy, but is really about using sensory integration theory from occupational therapy, as well as kind of emotional regulation theory from the kind of more trauma theory end of things, and integrating those in a useful way that can be used for teams and to work with service users on the wards, basically. So this feeds into a lot of things around, people being able to gain the skills to regulate their emotions, which in turn kind of, in theory at least, hopefully leads to a reduction in violence and aggression, and leads people to feel that they can cope better in the ward environments as well. So you can see we kind of have people who are leading on it from a staff point of view. We have a series of smaller goals broken down, and then just kind of keeping track of whether they've been achieved or not, and when we hope to achieve things by. Obviously, those dates get moved if for whatever reason we've been held up. So for this particular part of the strategy, we've been thinking about a kind of it's a sort of staff sensory room work. In fact, I've realised I'm going to talk about that a bit later in the presentation, but just an example of kind of the ways we've been structuring things and organising things to make it a bit more pragmatic, and so that people feel that we can keep track of and measure what we're doing and report back and think about where we're up to within each kind of individual area we're looking at. So I thought I'd just briefly talk through a few of the areas we've been working on, and then really open it up for a bit of discussion and any questions that people have. So in terms of staff training, I suppose that was our starting point, and I delivered to this group, I think in one of the earliest sessions probably, on the broader work we've been doing in Tower Hamlets adult mental health services around trauma-informed care, and kind of rolling out what we'd done was a kind of co-produced training day that we were rolling out to community staff at the time as a one-day training. And then we really picked that up. I took much more of an inpatient role after that, and so we picked that training up and adapted it so it was a bit more relevant to the needs of inpatient staff, and we've been rolling that out as a quarterly induction day for all new staff who come through the inpatient side. So yeah, it's a one-day introduction to trauma-informed care to really meet that idea that everyone who works in our services should be at least aware of the amount of trauma that's out there, the impact it's having, how to recognise it, all of those kind of basic level things that we hope everyone can be able to recognise. So that's delivered quarterly, and we've recently expanded it to include bank staff as well, because we identified that was a kind of missing cohort who do a lot of work on the wards, but actually weren't getting access to the same level of training. Also, we started early this year, myself along with some psychology colleagues from Newham and City and Hackney, things on the nursing have for different bands of nurses. Slightly different depending on which band we're delivering to, but they're a bit more specialist to the roles. So we've been delivering those as well. So they've been going well. So they're taking the basic level of kind of trauma awareness and pushing it a bit more into some of that specialist knowledge and thinking about how people can apply ideas a bit more practically as well. We've linked in with the Cavendish Square group, who have the safety in mental health settings kind of working group, which is a pan-London group of trust leads, and they developed some trainings based on kind of what they identified as needs within the trauma-informed care sphere. So there's a kind of a TIC-informed leadership program, and the Think Act, which is a sort of what they call a relational security program for anyone who hasn't heard of it. So it's all around kind of how to improve our relationships with the people who use our services in order to improve safety. So we've kind of sent people on these trainings, and some of them are trained the trainer programs. And then more thinking about staff support as well. I mean, we've long had reflective practice groups that are offered weekly to all the ward teams. And also we did debriefs for kind of serious incidents, but more recently we kind of have thought about that in a bit more of a trauma-informed way, and been meeting with teams to think about the needs of the team, not necessarily just after one serious incident, but if a team is feeling particularly burnt out, we've done things like have away days that are focused on staff well-being and thinking about burnout and moral injury and all those things. So that's been the kind of thinking about the staff side and training and support of that. In the future, we're hoping to roll out that Think Out training to everyone. Also have, again, tipping more into the kind of trauma skilled part of the pyramid, the next level up. Have some people identified as trauma-informed practitioners, and we've been developing some specific training sessions that we hope some staff from each ward will have a particular interest in this area and can access those trainings, as well as some specialist supervision and consultation around kind of trauma presentations on the wards that people can access. So that will be the kind of next stage, hopefully, and we'll probably trial that on one of the PQ wards before we roll it out to the rest of the unit. And we're also developing a training package based on some therapeutic engagement work that's going on. There's a QI, quality improvement project, that's recently launched across the different boroughs in adult mental health, which is around how ward teams can engage more therapeutically when they're doing observations of people on the wards. And so we're working with that project from a QI perspective to think about the training needs of staff in terms of how to have more therapeutic conversations, what that might look like. A big bit of the work which we started pre-pandemic, as I said, was this kind of work around emotional regulation and sensory integration. So the goal of that really is to train the therapy staff and all the ward teams in the theory side, but also then to be able to have people kind of use that in a way that means they can kind of integrate it into care planning. We've developed kind of some specific care planning based on a OT tool called the sensory thermometer that kind of incorporates emotional regulation, and thinking about that to kind of work with some service users to really map out with them where they struggle to regulate their emotions, where things are particularly difficult, but then also to kind of identify the gaps so that we can kind of give people specific skills to be able to regulate their emotions better. And then also sharing this information with the ward teams. So, if you have someone who is particularly kind of struggling with their anger, we can think about that with them in a care planning sense from a trauma-informed perspective, think about where they're having difficulties with that anger and work with them on strategies that we can also use to share with the team then. That also ties into kind of training everyone up in a trauma-informed use of the sensory rooms, which we have on some wards, but not all at the moment. But really, those are hopefully places that can be thought of as spaces where people can go and practice their skills and be able to, with the help of staff, kind of co-regulating, be able to bring themselves out of a state of fear, I suppose, or a state of threat. This work was all started kind of before the pandemic, and then we started kind of rolling out the training to teams that we developed, and we started doing the care planning work with some service users who we identified. And then the pandemic hit and all the sensory rooms got taken out of use because it was difficult to manage infection control in them. So it's been a kind of a slightly slow burn to get back to where we were, but we're picking up again in January, restarting the training with some teams, hopefully, and then get back onto the kind of individual care planning we've been doing. The last one I'll sort of talk about in a bit more detail, I suppose, is the user involvement and co-production and peer support side of things. So in a way, this has been the area we've lagged behind on. We've always obviously had kind of that very basic level of feedback about services, and we have things like community meetings on the wards where people can tell us directly their experience of care and what they want to see improved and try and operate and act on that feedback, I suppose. But we've never had a sort of active user involvement group or a sort of co-production group within the unit. And yeah, so I suppose we've acknowledged that is what we need now to push this forward, and to, yeah, obviously we can't identify more areas that need improving and think about how to improve those without the input of the people who actually use our services. So the next big thing, which we're kind of having active talks about at the moment, is getting a user involvement group in place, obviously with paid reward and recognition time. So yeah, we've got some meetings about that this week, and that will hopefully be the catalyst towards kind of getting some much more active user involvement in terms of kind of pushing forward the trauma-informed care strategy as well. In terms of peer support, we've got 2 peer support workers currently in the unit, and 2 more are due to start in the new year. So we're also thinking about how to create a kind of trauma-informed supervision group for those workers and give them kind of the support they need to be able to do the work that we're asking of them. I think in the past we've made the mistake of introducing peer support workers without a lot of thinking around the support they need necessarily, and so we've lost some people who found it kind of too stressful or overwhelming as an environment to work in. We might have been able to hold on to them. So we've kind of learned that lesson, and we're thinking about what support people might need in that role. And then I suppose briefly on some other areas that we haven't touched on as much, we've thinking about the physical environment, always a challenge for us because we don't own the buildings that our wards are in, so this always has to be done in kind of conjunction with the trust that does own the buildings. But we have put in some applications recently for some charity funds to improve some of the areas. It's fairly run down. Parts of the unit are fairly run down and need a lot of refreshing. And we also want to think about, there has been some work done actually on thinking about care planning, and there's been a lot of work actually recently in developing how we do care planning in the unit, and it's probably one of the strengths of the teams on the wards. But we need to kind of also harness that and think about how it feeds into things like ward rounds and people's overall care package. I will invite other people as well. Sorry, I've spoken a lot, I'm aware. I'll invite Stephen into thinking about barriers to implementation. But I suppose the obvious one that springs to mind has been kind of recruitment and retention, which I'm sure a lot of people have had some difficulties with. So there's high turnovers in all of the teams really, or in psychology in particular, we've struggled to recruit over the past couple of years. to offer some of those more specialist interventions as well. So, you know, obviously the high turnover and the difficulties in recruiting across all the teams just on people actually being able to have the time to engage in this work and think about it. But Stephen, apologies for kind of just talking so much, but I invite you in to think about either any other barriers or just things that I may have missed that you wanted to put in as well.
Yeah, thank you. So I did want to say a bit about the challenges, really, and I think when we open it up for discussion, it would be really helpful to get some feedback from this group about thoughts on whether we've approached this in the right way, really, and going forward, if there's a way of thinking about it differently. I think that there has been some fantastic progress, as Ryan has described, but I think it would also be fair to say that there's a bit of a way to go in terms of that aspiration for making our inpatient service truly trauma informed in every respect. I think, you know, we're very much not there yet. And I think that what Ryan has described is taking a project management approach and trying to have clearly identified goals in each area. And I think the reason that we thought about it in that way is that there has been a lot of different initiatives in the inpatient service, which could perhaps come under that umbrella of trauma informed, but maybe were not named or thought about in that way. And so we wanted to try and pull things together to acknowledge what's already been done, but also to identify some areas for improvement, really, and try to have a structured approach towards moving towards a more trauma-informed environment and having a time frame for that and having different people who were going to lead on each of those areas and sort of trying to make sure that it didn't get stuck, basically. I think that in a context where there are a lot of competing demands, it's easy for an initiative like this to get a bit stuck, not because anyone is against it or thinks that it's a bad idea, but just because it's difficult to prioritize all of the time. But I think that one of my worries about that is that it there's a tension between taking a hierarchical top-down kind of approach and having a bottom-up service user involved and co-produced approach. And I think in a way that is the bit that we've missed and need to do a bit more thinking about is the co-production element. But I suppose that the ward environment is difficult at times, and I think that it is quite understandable that one of the culture of the inpatient service is, I think, quite task oriented. And I don't mean that in a critical way, it's just an observation. And I think that the approach that we've taken is a way of attempting to fit in with that culture and that idea of setting some clearly defined tasks that people can do and get on with is kind of how things usually work in the inpatient service. But I wonder if one of the things that we might have missed is that that might not be the best way to affect culture change. And I worry a bit that having a steering group, which is made up mostly of the more senior people, is locating the change within that group and playing into that hierarchical top-down way of doing things. And maybe an alternative way of thinking about it could be that rather than having a steering group, we ought to be thinking about how we bring tech into all of the meetings and spaces that happen on the ward and trying to disseminate it as everyone's business. I think the challenge with that is that I worry a bit with increased service user involvement, that one of the unintended consequences could be putting responsibility for change on some of the least powerful people in the system. And actually, we do need to involve some of the senior staff in expecting and to some extent holding to account, making some changes and putting some things into practice. And I think the other thing that it's maybe worth saying is that it has been difficult to engage everyone in the system. I think that we've done quite a bit of work with our consultant psychiatrist colleagues. Ryan and I went to present to the consultant group, and our CD, clinical director for inpatient, has been quite honest about the fact that not all of our psychiatry consultants are necessarily keen on TIC. Sometimes people find it a bit patronizing. When they've been to presentations about it in the past, they've felt that it's telling them things that they already know while also implying that they might not be doing a good job. And that has put people off it a bit to some extent. So I think that what we've tried to do is dispel some of those myths, acknowledge the good work that people do, while also trying to inform people about what TIC is and isn't, because I think that sometimes that idea that we know it all already can get in the way of hearing new information. I think that if you sort of accept that some of it might be reminders of things that you already know, but also being open to the idea of maybe doing things differently in future can be a helpful way of approaching it. But yeah, not everyone always is able to hear how they might do things differently. So so that's just a bit of a flavor of some of the challenges. And in terms of the discussion and feedback from yourselves, I think it would be great to hear some thoughts about how we've approached it and how we could approach it, bearing in mind some of these challenges. So I think that neatly opens it up for questions and discussion.
Thank
Marisa,
you.
sorry, I just wanted to ask Marisa, because you've been involved in this work as well, if there was anything you wanted to add to what we've said.
Can you hear me?
Yes.
Okay. I don't have anything to add. You've covered it all. But I think one of the things that we've started thinking about in terms of sensory integration is calling them sensory-based approaches. So it's just a bit about language, because sensory integration is a full postgraduate training. So just something about language and how you support people to, think about themselves from a sensory perspective and help other people. But I'm meeting with one this afternoon. Much more conversation. But yeah, I think that you've really captured certainly the meetings that I've been involved in. Kind of the ambition and challenges.
Thank you.
I might just start the discussion. Thank you so much. I feel like you touched on a lot of really important and relevant points. And also I appreciate the kind of honesty and transparency and like inward looking with that, because it is not always easy. So thank you for that. And I think too, despite this being kind of a very specific setting, which maybe not everyone in the room can relate to in terms of their professional work, a lot of the takeaways are definitely relevant, and probably something that others may have come across in their own work in trying to make changes. So that's great. Tiago, did you have, I saw your hand kind of flash up and then back down. Did you want to come in?
Yes. Can you hear me okay?
Yes.
First of all, I have to say thank you so much for this wonderful presentation. I'm doing research in this area and I feel very passionate about the culture of the NHS being very top-down. And I work in schools, and without noticing, I think that I'm doing something that is similar to the project that you are trying to implement. So I started having reflective practice groups in schools for learning mentors and running grounding groups for staff, because all the schools have sensory rooms for students, but not necessarily for staff. So I'm just mind blown by everything that was said today. I think it's a very interesting project. I think that we have so much to learn from psychiatric units and how we can disseminate these to other contexts. And I'm new to the trust, and I feel that this trust is kind of a tectonic plate, and it has a different language from other trusts that I worked in. So I'm just very pleased that I was here and I learned a lot.
Thank you.
Ravi, do you want to come in?
Yes, please. First of all, that was fantastic. I learned such a lot. It's my first visit to this, and it was a lovely presentation, Ryan and Stephen. Really, really informative. There was a couple of things I wanted to pick up on. One was, I might have missed it, but I didn't hear anything about carers, and particularly for inpatients, family carers. All of that whole side of things is terribly important. They're huge allies for us. They're obviously very important for our service users, the immediate service users. They are our service users as well. And I didn't hear where I'm sure you are involving them actually, but maybe make it more explicit, because I think the trust does have a formal policy now on or a, what's it called? Not a policy. Strategy, thank you. I knew you'd get the strategy on carers, and I think that this needs to be linked up with that. That's one thing. The other thing I wanted to pick up on was the comment you made, Ryan, that it's just such a perennial problem, staffing and recruiting, and it's not going to get better anytime soon. Psychologists are becoming like hen's teeth a bit. They're so difficult to find, and that to me linked with another issue, which is the difference between training and supporting and embedding and culture change. They're not the same thing. They segue into each other, but they're not the same. And I think hearing the fantastic work that the psychologists are doing everywhere, with arts therapists as well and the OTs, but there's a very limited number of them, and you're spreading thinner and thinner and thinner. And that does not actually, it promotes awareness and all the rest of it, but it doesn't lead to the ownership of that culture in the groups that you're doing. And I'm aware the biggest group for us are the nurses. So for me, and I think Stephen, Ryan, I think you know a bit about this because of the moves that are around at the moment to think about reflective practice in all areas of the trust, which are not as well developed as they are in Tower Hamlets. That really this needs not to be a psychology or even therapies owned initiative. It needs to be owned by everyone. It needs to be that the doctors understand that this is part of what we all do. It is not a specialist skill. It is a way of, that's another layer, but providing trauma-informed care is something it's part of what we should all be providing. And that needs to be owned and supported and part of business as usual for everyone, not psychology-led. If psychology can support getting it going, but so that's just those were just a couple of points I wanted to make. But fantastic.
Yeah, thank you, Ravi. I think it's such a valid point, and it's always been the tension in a way between getting something started and being harnessing the people who have the passion for it in the first instance to get it going versus getting it embedded amongst all the groups as a kind of culture change, I suppose. But I think I think it is more in the language of a lot of professional groups, and there are, and I'm sure Dada will want to kind of come in as well and talk about it from the nursing perspective a little bit. But I think that's the other thing about resource, isn't it? It's around actually if we put the time into providing the training and the support for these staff groups as well, then hopefully that allows them to feel confident to be able to use some of these skills and going out there, and they're the people with, you know, more on the ground with more kind of resource to do it. So yeah, ongoing tension, but definitely worth thinking about more and highlighting.
Morning, everyone. Probably start with an introduction. Dadai and new Borough Lead Nurse in Tower Hamlets, and thank you for the invite. I suppose for me, it's a lot of agreement in terms of some of the issues that have been raised, but also celebrating the successes together. And, you know, just thinking about the engagement across the system, you mentioned that, Stephen, and, you know, working with the largest workforce in terms of nursing, I think we do need to get it right from the beginning. And when I'm speaking about we, it has to be a collective work, because we may run the risk of, you know, disengagement because people feel that it's been done to them, similarly to reflective practice, rather than doing with and recognizing the benefits of trauma-informed care, not just for the service users, but for the staff as well. You know, recently we've been doing some engagement work around observations with staff, and I think I maybe it's too early to say, but I think it's been successful in that it's been multidisciplinary, and the service users and carers have been at the core of that. So I think that also should be reflective in the trauma-informed work that we do. Yes, there is a voice missing in terms of medicine, in terms of psychiatry. And so I suppose that we can collectively think about how we can allay those fears or the doubts, or make it clear. I speak about the engagement work with observations because I think it's been an opportunity for nursing staff across bands to see trauma-informed work in action, embedded rather than just a theory. So I think if we take more opportunity to weave in trauma-informed care in QI projects, in work that we do, it can become more alive than just a construct that's, you know, that's just there. And I agree with the service users being involved, and I think that's why it's been important, Ryan, for us and Marisa in our conversations to just go back to the drawing board and start with service users, because I think just losing that voice, we're lost. There's no direction. What are we working with or working towards if we're not hearing the voice of the service user and the impact of our care? I don't know if my excitement about trauma-informed care is loud enough, but I think this is the way to go in inpatient services, even for staff support, even with reflective practices.
Yeah, thank you. I think that's really helpful. And I suppose just to pick up on Ravi's point, that it's service users and carers, I think it's helpful to be reminded that we need to be hearing that voice as well and bringing in carers also.
I think I see Charlotte's hand.
Hi, everyone. Thank you so much. That was such an interesting presentation. I'm sort of coming from outside of health angle, I guess, which may or may not be helpful. But I was really interested in the process that you identified of breaking things down into much smaller, more concrete kind of steps, because that seems to me to act absolutely in concert with the with the struggle of top down, bottom up, which I don't think you'll ever get away from. I think that's always going to be there. The NHS is an incredibly hierarchical institution, and it's made up of individual hierarchical institutions. So it's sort of a way of learning how to live with that rather than struggle with it in a way. But I was interested in the point around, you know, having more from service users, more from carers, and, you know, thinking about how can you get carers and service users on that steering group? Can you make more connection between the senior people and the steering group and the real people who are experiencing mental health inpatient service? And kind of work on it that way. And maybe you've already tried to, it just didn't come through to me. So that's one thing. And I think there's lots of parallels for us in, working in education in early years, thinking about how do we create the time in a very stretched service, very stretched, very difficult to retain staff, very difficult for staff to come to training. How do we keep the interest going in a way? And I think it is through these small steps, these small projects that feel meaningful and that people can begin to speak quite fluently about trauma-informed care without really knowing that that's what they're doing almost. So I take heart from it. Thank you.
Thanks, Charlotte. Yeah, I think it's an you know, the service user and carer involvement, I think we've had in terms of the community side of Tower Hamlets adult mental health. It's been a pretty enormous success over the past few years. That, you know, we've got some really active co-production and user kind of participation groups going on. So I think we've got a model to draw on in terms of bringing that in more and joining up those voices. I think though the learning from the community side when I've been involved in it is, you know, just how much of a commitment that needs and the time and resource. You know, it's not just something you can obviously sort of casually do and say, let's invite some service users along. It needs a lot of kind of structure and investment and people being released to do it. So I think that's, you know, that's what we've always grappled with on the inpatient side a little bit more is, you know, everyone just being completely stretched all of the time. But I think, as Dadai said, it's going to be a priority now to kind of get that side up and running and then link the two parts really. So I think that's really helpful reflection.
One, I guess on the topic of co-production and involvement, something that feels like it would be really important in this setting, but is the case everywhere, is around like clarifying the scope of involvement among the people that you're working with. So being really clear about like, this is the kind of, these are the boundaries within which we're working. Because I know sometimes people can get quite tired of always being asked to feed into things or what's your opinion about this, and not really seeing anything be different. And obviously you don't want people to feel disengaged from that, but I guess being really transparent about like, these are the things that we're able to change at this point. I'm sure that's something you've considered, but it feels very important in this setting.
Yeah, no, that's really helpful, Angela. Thank you.
Marisa?
Something you said just made me think about how obviously, of how we include service users and peer support workers in a trauma-informed way. And I think one of the things I was thinking about recently with an appraisal with the peer support worker was actually our HR policies don't work in a trauma-informed way, particularly for people with lived experience. And it's something you said, Angela, just kind of made me think, I wonder how we kind of can test some of that stuff out well in this inpatient, you know, kind of a discrete area of the work. So, yeah.
What do you mean by HR policies?
So, I mean, I know it's probably not the same for people who receive recognition and reward, but Ryan talked about our peer support workers, and so they have a contract and they are subject to the same kind of sickness reporting and the same, you know, the same kind of, are they fit for work kind of questions when you refer people to occupational health. And I think sometimes that language is quite exclusory. That's not a word, is it? But, you know, like it excludes people from the conversation of what does fit for work mean? How can we support you to be at work in an environment where you're a person with lived experience? I think, you know, and it's, you know, it has potential for when we bring people in, when we bring people with lived experience in and service users in to co-produce a trauma-informed care approach, you know, how do we make sure they feel safe? And yeah, I think when you were saying, you know, like we can't just say, what do you think? And then thank you very much, you know, ticking that box, but really like what's real co-production, which I know Mina will always be talking to us about. So yeah, it just reminded me of like, oh yeah, there's potential here for repeating some of our past mistakes, isn't there?
Good point. Actually, on the note of co-production, there is so Tower Hamlets Together, which is the local place-based partnership. Place is just basically the local authority level health and care and wider system partnership. There is kind of a task and finish group that's ongoing at the moment around mapping co-production in the borough and like, so what's existing and kind of providing also guidance for people seeking to do more co-production. So there should be resources coming out, and I think 2 workshops happening in the new year. So if that's something, I mean, I assume it's something that is of interest to lots of people in the room, so I will be sharing it across to the kind of full trauma-informed community practice mailing list. So do keep an eye out for that, because I imagine it's something that lots of people kind of grapple with, how to do this in the best way. And I guess something that we can always work on improving upon. Any final questions for Stephen or Ryan or the wider team, or any kind of concluding thoughts? We can wrap up a bit early today, but just wanted to say finally thank you to everyone that was involved in the project. Obviously lots of work has gone into this, and it's a great starting point, and good to hear that there's more plans for the future. And thank you, Ryan and Stephen, for presenting. And finally, again, a call out for ideas for future sessions. We do want to kind of keep it as it was today, like very much a learning environment. So open to that. Tiago.
Just wanted to ask if there will be more meetings in January, and when would these be?
I think that the first one in the new year is actually scheduled for February. So not scheduled in January, but there will be things like emailed out during that month. Thanks. Great. Well, thank you everyone for joining this morning, and I hope you have a good rest of your day, and thanks to our presenters.
Thank you all.
Thank you.
Take care
Bye.
and happy holidays.